So this is what I was able to prepare for you in transplantation immunology. So transplantation is a potentially life-saving treatment for end-stage organ failure, cancers, autoimmune diseases, immune deficiencies, and many other diseases, of course. So human leukocyte antigen system is a very, very large immunological barrier to the successful of transplantation. So human leukocyte antigens, as you remember, we discussed them yesterday. They are really very, very, very significant when it comes to transplantation. It consists of cell surface proteins that play a central role in immune recognition, initiation of immune response, because of the ubiquitous presence of the proteins on the surface of nucleated cells and the extensive degree of polymorphism. So an allogeneic response may result in a graft rejection in solid organ and stem cell transplantation, or graft-versus-host disease in stem cell transplantation. So in this case now, as you remember, because of polymorphism in human system, and of course that is a very, very extensive degree of polymorphism that contributes to the immediate graft rejection in solid organ and the stem cell transplantation, and even graft-versus-host disease in stem cell transplantation. So because of this high degree or extensive degree of polymorphism among human leukocyte antigens. So we talked about histocompatibility system, which is of course HLI antigens. So those are of course known as major histocompatibility antigens. So class 1 and class 2 are known. And they are located, of course, this is a set of proteins on chromosome 6, short arm of this chromosome. So we have inheritance pattern. Of course, they what you call the Mendelian fashion of haplotypes inheritance. You can see that we have two parents with red one and the other one which is pink and purple and red, not red really. So we have these haplotypes, but of course because of inheritance you'd see close among the genes or the haplotypes. So then they can give rise to the 4 offspring. So of course, as you can see, they will be able to pass the haplotypes to their offspring. So these are the combination of haplotypes among these offspring. Offspring receive one maternal and one paternal HLA haplotypes, and based on this Mendelian inheritance, there is at least 25% chance to any 2 siblings to inherit the same 2 haplotypes. There's 20% that 2 siblings will inherit the same 2 haplotypes. So there will be both HRA identicals. So a 50% chance of being HRA haploidentical, which means they can at least share one similar haplotype from both parents, right? And also 25% chance of being non-identical at all, which means they don't share any haplotype from parent. So that is what you call, of course, Mendelian inheritance, a possible Mendelian inheritance pattern. So HLA class 1 protein are the product of HLA, of course, HLA A, B, and C genes, and they are predominantly expressed on virtually all nucleated cell surface, covalently bound to beta-2 microglobulin. And class 2 heterodimers are the products of HLA, DR, DQ, and DP, depending on which gene that is going to be expressed. So Class 2 heterodimers are codominantly expressed primarily on antigen-presenting cells, of course, including monocytes, a dendritic cell, macrophage, as well as B lymphocytes. So they exhibit a human leukocyte antigen, class 2 of the HLA. So HLA proteins have critical roles of development and functioning of the innate and adaptive immune system, and they also serve in recognition of antigen receptors for T lymphocytes, initiating, of course, adaptive immune response. And in addition to, they serve also as ligands for regulatory receptors on natural killer cells in innate immune response, because natural killer cell is involved in innate immune response. So the CD8 molecule on cytotoxicity T lymphocytes. Of course, those are called cytotoxic T lymphocytes. The CD8 bearing cells interact with the class 1 HLA proteins, whereas, of course, HLA2 interact with the CD4 molecule on T helper cells. You remember that is how the CD molecule interact with the human leukocyte antigen in terms of presentation of an antigen. So the problem now that happens is that the key feature of the gene encoding for human leukocyte antigen protein is an extensive degree of polymorphism. So this degree of polymorphism helps human leukocyte antigen to bind peptides from very many array of pathogenic organisms and then generate protective immune responses. So while this has successfully enabled the population to survive infection challenges, but it has also become a very, very serious challenge in transplantation of a tissue between two people. So it has been a very serious challenge, even though, of course, the polymorphism of a human leukocyte antigen help very well in infection control. So now we have, apart from major histocompatibility antigens, we also have a set of minor histocompatibility antigens. So this set of transplantation antigens was identified in human demonstrating tissue rejection in MHC identical transplant, and based on outcome of human stem cell transplant between HLA identical siblings in whom graft-versus-host disease has developed. So those proteins are said to be minor histocompatibility proteins because, in fact, after following transplantation or of course, transplantation of a certain graft or a certain organ or even human stem cells, after that they will develop reaction or rejection, which is, of course, in terms of graft-versus-host disease or even any other rejection of the grafted tissue or organ. So any reaction that develop after this transplantation between identical HLA or major histocompatibility complex identical individuals, that will be attributed to minor histocompatibility antigens. So studies documented a slower rejection pace mediated by these transplantation antigen. Thus, the name is minor histocompatibility antigens. So because the reaction that is shown, it is now of a slower pace or slower rejection pace. So other different types of minor histocompatibility antigen has also been identified. So those are also encoded on the chromosome Y, a protein for which the recipient has homozygous gene deletion, proteins that are autosomally encoded, and proteins are mitochondrial DNA encoded. So these are some of the minor histocompatibility proteins that you recognize causing incompatibility, especially when major histocompatibility are actually identical and compatible, but still we are able to see the reaction of rejection even after transplanting or a tissue between two identical individuals with the same major histocompatibility antigens. Now, what about ABO blood group system, and what is the role that is played by ABO system or ABO blood group antigen? So ABO system is the only blood group system that impacts clinical transplantation. The only ABO system is the only blood group system that impacts transplantation because in fact, ABO blood group incompatibility is a barrier to solid organ transplant because their antibodies can bind the corresponding antigen that are expressed on a vascular endothelium. Of course, vascular endothelium of that graft of the engrafted organ. So the vascular endothelium can suffer antigen and antibody reaction, especially when the recipients of the tissue or recipients of the organ is not the same blood group with the donor of that tissue. So that's why also ABO blood group system is also very, very, very significant when it comes to transplantation of tissues. So binding binding activates the complement cascade, which then leads to the hyperacute rejection of the transplanted organ. As such, recipient donor pairs must be ABO identical or compatible to avoid this adverse outcome. So that's why in order to avoid the hyperacute rejection, so we must make sure that the patient that we are transplanting and also the donor of that graft or that tissue or the organ is ABO identical and ABO compatible to avoid this problem. So ABO blood group system can cause hyperacute rejection of patient of the graft. So in fact, some recently approach using plasma exchange and intravenous immunoglobulin administration has allowed successful transplantation of kidney from ABO incompatible donors by lowering ABO antibody to level that allow transplant to proceed without risk of hyperacute rejection. So this is what we call plasma exchange. Plasma exchange and intravenous immunoglobulin administration. That is like trying to remove antibodies that can mediate that hyperacute rejection, especially those antibodies against ABO antigens. So, transplantation of cells or tissues between two people is classified by the genetic relatedness of the donor and recipient, and autograft is a transfer of a tissue from one area of the body to another. Of course, this is what you call autograft, but synergic graft is a transfer of a cell or tissue between identical twins, and allograft is, of course, a transfer of tissue between two individuals with the same species, and also xenograft is also a transfer of tissue from a person to maybe from an animal to a person, that is between individuals of different species. That's what we call xenograft. So that happens, of course, for some animal tissues can be transplanted to humans. So that's what we call the xenograft. So as stated earlier, so disparity or incompatibility between donors and recipients will result in vigorous immune response to the foreign antigens, especially the human-equated antigen, and that is what is going to stimulate or to mediate a graft rejection. So the response to foreign major histocompatibility antigen of that graft is then characterized by a very strong cellular and even humoral immune response. And basically, in your basic immunology, because we can't go through everything in immunology, you know that immunology is very wide, and we are supposed to have very good basic in immunology because to understand transplantation, it is very important to have a very good basic in immunology and very good background in immunology because here you have different terms and you need to understand. I don't need to explain, but you need to understand. So that's why we need to have that package before these very, very tough topics, especially when it comes to transplantation or tumor immunology. As we're going to see later, tumor immunology, but also this one also requires you to have that package. So stronger cellular immunity and immune response, which of course involves immune cells and humula, which mainly involves antibodies, but also not forgetting cells. They are also involved in humoral immunity, but of course, cells, antibodies, play a very vital role, including, of course, complement proteins playing a vital role in humoral immune response. So the recipient's immune system recognizes foreign HRA proteins in two distinct mechanisms. Of course, that is the first thing that immune system can recognize a foreign tissue in two mechanisms. The first is direct allo recognition and indirect allo recognition. So this direct allo recognition, recipient T cells binds and respond directly to foreign HRA proteins on a graft cell, either through self HRA plus peptides or foreign HRA proteins. So what you call self HRA plus peptides, what's the meaning of this? Self HRA plus peptides, this means human leukocyte antigen of the person, of the recipients of that graft, right? Human leukocyte antigen on the antigen presenting cells plus a peptide which is processed from a foreign graft. That is the antigen which is going to be presented to a lymphocytes, right? T lymphocytes. So that's what you call self HLA plus a peptide. So this a peptide is what is going to be presented to the T lymphocytes. So, and also sometimes foreign HR proteins without even presentation. That is also the way immune system can be able to recognize the foreign proteins, especially foreign HR proteins. So in either way, direct recognition is characterized by high frequency of responding to lymphocyte compared to the responder frequency in a typical T cell response for foreign antigen. So that is this is the bottom line of our mechanism here. So we want to say that the response that happens when someone has received a tissue or an organ as a transplanted organ or tissue, so the reaction or the response of T lymphocyte the frequency is very high comparing to the normal frequency of the T lymphocyte reacting to a foreign antigen, for example, bacteria, for example, a virus. So this reaction is very high with high frequency than what could happen when this lymphocyte was reacting to the foreign antigen. So the high frequency of responding T lymphocytes may be because of different factors. The first factor is recognition of multiple amino acid disparities by T lymphocyte clones. The presence of multiple different peptides on allogeneic cell that recognize different T lymphocyte clones, and the presence of many foreign molecules for per cells resulting in activation of T lymphocyte with low affinity. So there are many reasons, but the main reason and the denominator of this is that human leukocyte antigen exhibit very, very, very extensive polymorphism. So which makes T lymphocytes to be activated in multiple clones, or multiple cells are going to be activated in different clones, which makes the reaction to be very high with a very high frequency. So that is why the reaction against HRA molecules or HRA foreign antigen is not the same as reaction happens with just normal antigens, like for example bacteria or any other antigen, because of the disparities or because of the diversity and polymorphism among human leukocyte antigens. So now, what is indirect allo recognition is now the second pathway by which the immune system recognizes foreign HRA proteins. So indirect recognition is analogous to the normal mechanism of recognition of foreign antigen, as it involves the uptake of parsing, processing, and presenting antigen by the recipient's antigen presenting cells, and also they presented them to the T lymphocytes. So as you can see now, indirect recognition is just a normal presentation that happens when a foreign antigen is being processed by antigen presenting cell, for example, of course, more specifically, dendritic cells. They are the best, right? And also monocytes and macrophage and the B lymphocytes, which can present the foreign antigens. So that is what you call indirect allorecognition. But as you can see, in direct allorecognition, immune cell can be able to recognize just directly an antigen on a grafted tissue, or it can just recognize it when the antigen holds or express a certain peptides on its HRA molecule and presented directly to the cell. That is what leads to cell death, which is of course a graft rejection. So, but indirect, in fact, involves normal process of processing antigen and present it to the T lymphocytes for recognition. So, in fact, the indirect allorecognition plays a predominant role in acute and chronic rejection of tissues. So, we shall see those steps: hyperacute, acute, and chronic rejection. So some of these mechanisms, of course, are seen in the effector response against a transplanted allogenic tissue, include also direct cytotoxicity, which is direct destruction of the cell bearing that foreign antigen, right? Delayed type hypersensitivity response, you know what happens in delayed type 4 hypersensitivity, we talked about it, and the antibody-mediated mechanism as well, of course, because also antibody-mediated mechanism can also be involved here. So antibody may also mediate antibody-dependent cellular cytotoxicity reaction and may fix complements resulting in cell death. So there are so different mechanisms, but antibody-dependent cellular cytotoxicity reaction, it involves presentation or marking or what you call opsonization of antigen by the antibody, of course, which leads to cellular effects or cellular damage of the antigen of the antigen-bearing cells. Now, so let's look at the transplant rejection. Transplant rejection. So transplant rejection, there are three main mechanisms of transplant rejection. The first mechanism is hyperacute rejection. And what is hyperacute rejection? Hyperacute rejection occurs with very few minutes, within very few minutes to hours after vascular supply to transplanted organ is established. So this is vascular supply. So forget about waiting for days or transplant a tissue but you don't supply blood. So after vascular supply of blood, of course, after finishing transplantation, you must supply blood from that patient because tissue needs oxygen supply. After establishment of blood supply to that organ transplanted, so that's what happened, is called hyperacute rejection. So this type of rejection is mediated by preformed antibodies that react with the donor vascular endothelium. So ABO, HRA, and certain endothelial antigen may elicit hyperacute rejection. So as you can see, in hyperacute rejection, now what is involved is normally antibodies against ABO, against HRA, and maybe other endothelial antigens. So that will cause hyperacute rejection. So binding of preformed antibody to alloantigen activates the complement cascade and clotting mechanism and leads to the thrombus formation. So this is what happened after hyperacute rejection. It is, of course, complement cascade, clotting mechanism. Of course, also clotting factors are activated, which leads to thrombus formation. So the result is ischemia and necrosis of the transplanted tissue. So you can imagine within 1 hour or within a few minutes, the tissue now is suffering ischemia, and of course, laterally necrosis of the tissue. This is a serious hyperacute rejection. So hyperacute rejection is seldom encountered because donor-recipient pairs are chosen to be ABO identical or compatible, and patients awaiting transplantation are screened for the presence of preformed HRA antibodies. So in addition, of course, the absence of donor HRA-specific antibodies is confirmed before transplant by the performance of a close match test. You remember yesterday we talked about various close matching tests to identify antibodies against human leukocyte antigen. So this approach have virtually eliminated hyperacute rejection episodes. So this is advanced technologies that we are using. Of course, first of all, you cannot transplant a tissue. That can be a very, very serious mistake. You can transplant a tissue before you confirm identical compatibility in ABO system. Secondly, you must always determine if there are preformed HRA antibodies against the tissue, so in order to avoid this hyperacute rejection. Some people possess very low levels of donor-specific antibody. That's also a problem. Some people who are waiting for transplantation, sometimes they have very low levels of donor-specific antibodies in their blood, right? In their body. So in this case now, antibody-mediated rejection may take place after some days. So because, of course, they possess very few antibodies, right? But those antibodies cannot act immediately, so it will take some days, and this has been termed as accelerated rejection. So like hyperacute rejection, accelerated rejection involves also intravascular thrombosis and necrosis of tissue, of donor tissues. So that's what happened. Of course, accelerated rejection, you have to remember that it's the same as hyperacute rejection, but it doesn't happen just immediately. So it takes some days, but when it happens, the same levels, the same degree, and the same extent with hyperacute rejection. So the second rejection is what we call acute cellular rejection. So days to weeks after transplant, people may develop acute rejection. Days to weeks. So that one I hope is going to be very easy question for you. Days to weeks after transplant, people may develop acute rejection as well. But this is a cellular type of rejection, but may also involve antibodies as well. So it is a cellular type of rejection, but which also may involve antibodies. Acute rejection is characterized by parenchymal and vascular injury, interstitial cellular infiltrates which contains predominance of CD8 and CD4 cells, and also macrophage. So acute rejection involves most commonly cells, but also antibodies. So it is a injury of the parenchymal tissue and vascular injury, so blood vessels. So interstitial cellular infiltrates may also contain within the tissues, may contain CD8 cells, CD4 cells, and even macrophage. So CD8 cells are also called cytotoxic cells. They can, of course, become cytotoxic and produce and destroy foreign cells expressing foreign MHC or expressing foreign HLA antibodies, antigens. But CD4 cells that are present here in these infiltrates, they are there to produce cytokines and also to induce delayed type hypersensitivity reactions. Antibody which may be involved, they are just binding to blood vessel walls, activating complements, and inducing transmural necrosis and inflammation, as opposed to thrombosis, which is seen in hyperacute. So in acute rejection, no thrombic formation or no thrombotic formation that takes place. Only there are serious issues, for example, cytokines and inflammatory reactions, destruction of tissues, and activation of complements, and even induction or inducing transmural necrosis. So these are some of the mechanisms taking place in acute rejection. So now, chronic rejection is also another situation happen. So chronic rejection results from process of graft atherosclerosis characterized by progressive fibrosis and scarring with narrowing of tissue or blood vessel lumen due to the proliferation of smooth muscle cells. So this is what you call a chronic rejection. So this results from just a graft atherosclerosis. And graft atherosclerosis is also infiltration and fibrosis, and of course lack of blood supply, right? Because of the narrowing of blood vessel lumen because of proliferation of smooth muscle cells in that lumen. So several predisposing factors may impact the development of chronic rejection, including prolonged cold ischemia, reperfusion, acute rejection episodes, and toxicity from immunosuppressive drugs. All of them can contribute to chronic rejection. So chronic rejection is also thought to have immunologic components, especially sometimes delayed type hypersensitivity reaction can also induce chronic rejection. So in addition, there are also impact of CD4 molecules, CD4 cells, BD4 sites, cytokines, growth factors can also cause even interferon gamma. Interferon gamma, it is also very serious. It's a very serious cytokine. Interferon gamma can also induce chronic rejection. Now, something else that you know, which is called graft-versus-host disease. Graft-versus-host disease. So what is graft-versus-host disease? It is not transfusion associated. Here it is another thing. It is called graft-versus-host disease. What is graft-versus-host disease? So stem cell transplant, or sometimes lung transplant, liver transplant, are complicated by a unique allogeneic response, of course, which is called graft-versus-host disease. So, especially, of course, let's talk about stem cell transplant, because stem cell transplant is most commonly associated with graft-versus-host disease. So, recipients of stem cell transplant for hematologic malignancy may have depleted bone marrow prior to transplantation as a result of chemotherapy used to treat malignancies. So before transplantation of the bone marrow as a stem cell, they may be suffering even from depleted bone marrow cells before even transplantations. So next, the donor bone marrow, or more commonly peripheral blood stem cells, are infused. So when we infuse bone marrow, the infused products often contain mature T lymphocytes, and these cells may also have several beneficial effects, including promotion of engraftment. Right, make sure that engraftment or tissue is going to survive. Right. Reconstitution of immunity. This is also another thing. Of course, remember what is reconstitution of immunity. That is like restoration of immunity of that patient, right? And mediation of graft versus leukemia effects. What is graft versus leukemia effects? That is like trying to overcome leukemia effects, but by that graft. So that is what we call graft versus leukemia effects. However, also these mature T lymphocytes may also mediate graft versus host disease. So acute graft versus host disease occur during the first 100 days after infusion of the stem cells or peripheral stem cells, and also the targets the skin, gastrointestinal tract, and liver. So in mismatched allogenic stem cell transplantation, the targets graft versus host disease are mismatched HR proteins, while in matched stem cell transplant, minor histocompatibility antigen play a role, and they are the target of those antibodies. So the infused, those cells, because here in graft-versus-host disease. What is being involved and what is contributing is T lymphocyte, but not antibodies at all. So the infused T lymphocyte can mediate graft-versus-host disease in many ways, including massive release of cytokines because of the large-scale activation of the donor cells by major histocompatibility mismatch proteins and by infiltration and destruction of tissues. So in the effort to reduce this problem, several approaches are taken, of course, including, first of all, immunosuppressive therapy in the early post-transplant period and removal of T lymphocyte from the graft. That can also help. It is almost the same mechanism as what happens in blood transfusion-associated graft-versus-host disease. It is also the problem of T lymphocytes. So T cell reduction is very effective in lowering incidence of graft-versus-host disease, but it can also reduce graft versus leukemia effects. So it is also a problem, and also it can increase a problem of graft failure. So this is also a problem when you attempt to reduce T lymphocytes because you need them, because patient needs them, especially for promotion of engraftment, restoration of immunity, and what we call graft versus leukemia effects. That is, trying to overcome leukemia effects with use of this graft. So, but also you can reduce them in order to avoid this problem. So beyond 100 days, when it happens after 100 days, it's no longer called acute graft versus host disease, but it is now called chronic graft-versus-host disease, which of course sometimes leads to fibrosis of the skin, eyes, mouth, and mucosal surface. Now, finally, let's try to talk a little bit about clinical histocompatibility testing. Yes, I forgot. Yeah, this one was discussed yesterday. I forgot to remove it from this because I was planning to remove this clinical histocompatibility testing from this topic, transplantation immunology, because in fact we have it also in HRI testing. So we have them. We have genotyping using sera. We have DNA-based methods. We have detection methods. So we have even this one, microlymphocyte toxicity. We discussed it yesterday. So we have all these things in that yesterday course. So if you want to review it, you can maybe go back to the yesterday topic and read through. Even if, of course, yes, even flow cytometry, we discussed it yesterday. You know how it works, and yeah, everything was discussed. And even multiple single antigen beads immunoassays, this one that we discussed, because we use just a microwell where we can put so many antigens in order to detect them using antibodies, using serum, right? So all of them are discussed, and even advanced techniques, of course, including paternity testing and DNA technology. So this is about transplantation immunology. So later we will discuss tumor immunology and see what happens. But otherwise, I really appreciate your attendance, your attention. But of course, because we are going to upload this video, because we are recording, so when you want to review and revise, you can go back and watch the video. So I really appreciate. I'm managing my best. I'm doing my best to upload all the videos just next to the content on our website. So if you want to visit the website and watch this video, you'll be able to see it there next to the specific content. Specific topic. So if you read transplant immunology, then you'll be able to see next will be this. So thank you so much. God bless you. But of course, I wish you to be attending, not just to say I'm going to wait for the video, because there's no time for videos. Sometimes there's no time to watch a video, but you can still attend and be together with me. So thank you so much. God bless you, and see you.